Good afternoon, Professor Wheeler. First of all, thank you so much for taking the time to talk with us today. It's truly an honor to have the opportunity to hear from you directly. Your extensive experience in pediatric endocrinology and your forward-thinking approach to diabetes technology are both incredibly inspiring for us. Today's interview mainly focuses on your perspectives in managing type 1 diabetes in children, especially how technologies like CGM and hybrid closed-loop systems are shaping clinical outcomes. We are also keen to hear your thoughts on patient engagement, challenges in real-world implementation, and any insights you might have from your own practice. We really hope this can be a relaxed conversation. If there's anything you'd prefer to skip or elaborate on, please feel free to let us know. Shall we begin now?
Yeah, great. Thanks. Nice to be here. Ni hao.
Okay, so Professor Wheeler, you have rich experience in managing pediatric diabetes. Could you share some most common clinical patterns or misconceptions you observe when children with type 1 diabetes first seek medical help?
Yeah, right. Well, it's a good question. About a third of our patients present with DKA, and that worries us. So DKA is when they become very unwell and develop acid in their blood at new diagnosis particularly. Maybe 30% in New Zealand, but in some countries up to 50% present like that. That can be life-threatening. So that's a misconception that we would like to keep educating people about. We want people to recognise the signs and the symptoms of diabetes. We want them to get help early. If we can treat people in hospital or in the community with diabetes before they become very sick, it's a much less burdensome experience for them, a less dangerous experience for them. And we also get better control of their glucose levels and health much faster if we get them when they're healthy.
Okay, great. Thank you. So the second question, has the incidence of pediatric type 1 diabetes been increasing in recent years? What might be the contributing factors?
Well, that's a really interesting question. People are debating that at the moment. As a general rule, the incidence has been gently increasing around the world. There's a bit of debate about whether that's plateauing out or whether it's still increasing. Some countries, of course, have faster rates than others. So New Zealand and some parts of Europe and other parts of North America, we have much higher rates than, for instance, here in China. But rates are sometimes gently increasing despite that. Some people have wondered whether things like the COVID infection could increase the incidence of type 1. I've not seen any convincing evidence of that, but what we did see is with COVID, we saw more children sicker. So we saw people with DKA more, and certainly in New Zealand we've seen that. So we want people to come to get healthcare earlier rather than later, and not be scared to come to hospital.
I see. Thanks for sharing your thoughts. Okay, so we go forward with next question. How do parents respond to using CGM? Are there any common concerns or misunderstandings?
Yeah, well, in my experience, parents love CGM. Very, very rare in my experience that they would want to stop using CGM. So in my mind, there is absolutely no doubt that CGM is the gold standard method of glucose monitoring in children. In our clinic, we use a lot of CGM. We use it with parents, with children, and with adults. And I think regardless of age, CGM is the right thing for us to be using. Once we explain to parents that it reduces their burden, so the burden from finger pricking is very great. It saves them time, but most importantly, it's safer. And so I have no qualms at all recommending, high quality CGM products to any of my patients or families.
What key role does CGM play in real world pediatric diabetes management?
Yeah, as I said, now clearly the gold standard. All the major international guidelines state that if it's available, CGM should be placed on people with diabetes as soon as possible after diagnosis. In the real world, use varies. But anything you and I can talk about today that helps people get CGM earlier would be a good thing. I would love to see more people around the world, in China and New Zealand, using CGM more. So Anyone listening to this, if it helps, I would love that. In the real world, in my experience, as soon as a child is diagnosed with diabetes, I put CGM on them. So normally within 12 hours of being diagnosed, they would be wearing CGM if possible. CGM, fortunately, in my country is reimbursed, so that we're very lucky with that. And I understand that in other parts of the world, there remains big equity questions around access to CGM. But in the real world, if possible, I would put it on at diagnosis, and we would use it continuously throughout the life of that individual from the time they start.
Great. Hope one day China, we can also have the reimbursement expand for including more people and to use the CGM freely. So that's also our goal.
Yeah, no, well, equity of access is a huge issue, and we want more people worldwide to be able to access it.
Great. Thank you. So next question. Blood glucose targets different for children compared to adults. Do you adjust the goals for different age groups?
Yeah, that's a cool question. Yeah, well, absolutely. I think targets need to be individualized at times. There's certain population groups, the elderly, the frail, people with other complex medical illnesses, where we might be more relaxed with targets. But as a general rule now, the more time that goes by, in healthy populations, be they young or old, we are generally pushing for more aggressive targets. So in any young, healthy person right through into healthy adulthood, I have no problems recommending aggressive glucose targets. And more, we're moving from time and range, so the time between 70 and 180 milligrams per deciliter, or the time between 3.9 and 10 millimoles per litre. We want at least 70% time in that range, but ideally way more. And more we're interested in time in normoglycemia, so that's the time between, say, 60 and 140, or 3.5 and 7.8. We'd love to maximise that time. So we're very aggressive. We want people to be as close to normal as possible. And only CGM and automated insulin delivery allow us to achieve that.
Great. Thank you for sharing your thoughts. Some believe children with type 1 diabetes shouldn't eat sugar or fruit. Is that accurate?
It's a nice statement. I think this is my opinion, and I think most guidelines would agree that the ideal diet for a child or an adult with type 1 diabetes is no different than the ideal diet for anybody, any other human being. The main problem with the modern world is we eat too much refined carbohydrate, too much processed sugar and carbohydrate in general. And so it's not unreasonable that we would be encouraging people with type 1 diabetes and people without diabetes to be eating less of those products. We do quite strongly recommend less snacking for children with type 1 diabetes and adults with type 1 diabetes. So we try and stick people to their main meals if possible, with either low carb snacking or less snacking in between meals.
Okay, so how do you think about Diet Coke? Do you think it's safe for children with type 1 diabetes?
Yeah, we're probably straying a little bit beyond my expertise, but Diet Coke, I think the same thing for all humans, anything in moderation. I think a little bit of treat products like soft drinks, products like that is okay. But all humans should be very cautious with their intake of those products.
Yes, fully understand. Thank you so much. Does exercise often cause hypoglycemia? What precautions should be taken before or after physical activities?
Yeah, well, a lot of people are worried about that. Exercise and diabetes is something we need to be mindful of. I guess first and foremost, I would like to say, in my experience, there is absolutely no reason why people with diabetes can't exercise successfully and can't perform at the highest level of sport with diabetes. So I do not see it as a barrier at all. And I guess that's what I'd like people listening to take away, is if we manage things right, if we work with people correctly, I see the sky's the limit of what their potential is when it comes to exercise. So yes, exercise can contribute to hypoglycemia, but with modern technology like CGM, automated insulin delivery, and with the right education, anything's possible.
Okay. So the last question from my side is, while most complications occur in adulthood, what early risk factors do you pay close attention to in children with type 1 diabetes?
Well, right from diagnosis, I would stress the importance of getting good time in range and as much time in normoglycemia as possible. We are definitely moving away from a time where we encourage people to be more relaxed about their glucose levels. But the great thing about technology is we can get more time in range, more time in normoglycemia without more burden and with less risk of hypoglycemia. So the acute complications are hypoglycemia and DKA. In my experience, technology helps with both of those. In the long term with children, look, my dream is now that we're treating them more carefully, using the best available treatments, I would like to see them living in a world where there's a lot less complications.
Professor Wheeler, I will take over the rest of the questions. First question, when addressing nocturnal hypoglycemia in children, what interventions do you typically prioritize?
It's an important question. So in terms of, there's both insulin delivery, there's management of exercise, and then are there technological options that could help prevent that? There's no doubt that CGM helps prevent nocturnal hypoglycemia. It prevents it in the sense that it'll alarm, and then a person with diabetes or their parent can intervene and protect them from more severe hypoglycemia. The gold standard management of people who are having difficulties with nocturnal hypoglycemia is automated insulin delivery. There is no doubt about that.
Yes, sure.
And on automated insulin delivery, the rates of nocturnal hypoglycemia and any form of hypoglycemia dramatically reduce.
Because many people will ask us how to prevent this situation to come. So we always told them to turn on the alarm with their CGM. A lot of people can use this to prevent this situation in children or other types.
Yeah, well, in my clinic, maybe 90% of people are using automated insulin delivery. And I now encourage them to put their alarms lower because they're so protected by the automated insulin delivery. We don't need the burden from such alarms that are too high, pushing the alarms lower and lower, letting them sleep.
But they still can feel it.
Yeah, and the machine will protect them, and it will alarm if it goes too low. But now we're pushing those limits into much more normal levels rather than artificially higher levels.
Thank you. The next question. Have you encountered T1D children with coexisting thyroid or other autoimmune conditions? Does this complicate management?
Yeah, well, we do see that. In my clinic, maybe at least 10% of the young people in my clinic have celiac disease. So celiac is very common. That's the most common of the autoimmune diseases I see in New Zealand. Thyroid disease in children is rarer. Maybe less than 5% of my clinic would have an autoimmune thyroid disease.
Yeah.
But in adulthood, the rate of that, both those things accumulate over time. And there are some other rarer autoimmune diseases we see as well, but they're rarer. Yeah.
Thank you for sharing your experience. Do many children with newly diagnosed T1D still present with DKA? How can early detection be improved?
Yeah, we talked a little bit earlier about that, and yes, in New Zealand, in our experience, about 30% of children present with DKA. In some countries in the world, that rate may be above 50%. So there is a major issue there with how we protect children around the world, how we educate people, how we improve health system access to prevent DKA. I think the key thing is we educate healthcare providers first and foremost, and ideally we find ways to educate people to seek help from a healthcare provider as soon as they can if their children or themselves are feeling unwell.
Yes, thank you. That's an important question, I think. Besides HbA1c, what other indicators do you use to assess glycemic control in children?
Yeah, well, HbA1c is the traditional measure. More and more now in my clinic, we partner that with CGM metrics. So again, almost 100% of the clinic now using CGM. In fact, we mostly go on CGM metrics, although we remain interested in HbA1c. So whenever we see them, we're looking at the CGM download, we're looking at their time in range for the past 2 weeks, and we use time in range, time below range, and time in normoglycemia as much as we possibly can.
Yes, true. Is the closed-loop system equally suitable for children of all ages? What barriers remain in clinical adoption?
Yeah, well, there are barriers, there's no doubt about that. There is no doubt in my mind, regardless of age, whether you're elderly or whether you're very young, automated insulin delivery is the gold standard method of treating diabetes in 2025. You know, what happens in the future, I don't know. But at the moment, automated insulin delivery is the gold standard, so regardless of age. So the people I put on first are the youngest children I treat. I put them on automated insulin delivery as fast as I can. The last 2-year-old I had just in recent weeks, within 12 hours they were running automated insulin delivery. So in my mind, in younger children, that's the best method to help manage the burden. It's an enormous burden, enormously stressful for families, and automated insulin delivery can help with that burden.
Yes. The last question is, what questions do parents most often raise when using closed-loop systems?
Oh yeah, what questions do they ask? Well, in my clinic, they're mostly asking if they're newly diagnosed, how soon can they get it? That's the biggest question I get.
Okay.
They know about it, they're talking about it, they know our team is interested in it. And I think the reality is if you know you can, on one hand, treat diabetes with numerous injections a day, or you can have a pump and automated insulin delivery. In the current environment, there's no choice. Almost everyone will want to wear a pump.
Okay, before we conclude, can I have a personal question? How do you feel when you're trying on our CGM?
Oh yeah, well, for the first time ever, I've never worn a Lynx CGM, and currently I've got no patients using that system, so I can honestly say that. I think it was a very nice insertion.
Yes, thank you. Thank you very much, Professor Wheeler. That concludes our questions for today. It was a really pleasure speaking with you, and we truly appreciate your time and the insights you shared. We look forward to keeping in touch and hopefully working together more in the future. Thank you.